Good afternoon, everybody. I'll get us started. My name is Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome to today's Public Health Conversation, our first of 2021. These public health conversations are meant as spaces where we can engage with the full complexity of the issues that shape health, coming together as a community to exchange ideas and learn from our guests. Before we begin, I would like to thank our co-host, the Milbank Quarterly, represented here by our distinguished speaker and the editor. I would also like to thank Meredith Brown and Alicia Noel for their work putting today together. Thank you. The day after Donald Trump was elected president, our community convened to discuss what this political upset could mean for health. Those of you who were there may recall a feeling of anxiety for what the next 4 years might bring. Now that those years have passed, we can say, I think, that concern was justified. President Trump's term was in many ways a photo-negative version of a politics that supports health, and a reminder, yet again, of how important politics are to shaping health. Today, we are convening on the first public health conversation of 2021, specifically here to discuss a political sea change. The Biden-Harris administration has a chance to create a healthier world now and in the future. I'm very much looking forward to a robust and hopeful conversation about how it can do so and to learning from each of our speakers. It's now my great pleasure to turn the screen over to our event moderator. Professor Alan Cohen is a research professor at the Questrom School of Business and professor of health law, policy, and management at the School of Public Health. He's a good colleague and friend. He's the editor-in-chief of the Milbank Quarterly, and he was, in many ways, the intellectual architect of today's event. Alan, thank you. Over to you.
Thank you, Sandro, for that introduction and for the invitation to moderate today's conversation in health. I am doubly pleased to be here, not only as a faculty member of the School of Public Health and the Questrom School of Business, but also as the editor of the Milbank Quarterly. The subject of today's conversation is especially germane to the Quarterly. Back in November, immediately following the presidential election, we launched the Building Back Better series of opinion essays by noted experts on a variety of health-related issues. These essays offer policy ideas and guidance to the new Biden administration, and we invite you to visit our website at www.milbank.org/quarterly. Thus far, we have posted 12 essays, and a 13th will go up tomorrow. It is my pleasure now to introduce the members of our distinguished panel. Each is a thought leader in population health and health policy, and I am extraordinarily proud to say that all four are members of the Quarterly's editorial advisory board. First, we will hear from Dr. Elena Fuentes-Afflick, professor and vice chair of pediatrics, chief of pediatrics at the Zuckerberg San Francisco General Hospital, and vice dean for academic affairs in the School of Medicine at the University of California, San Francisco. Dr. Fuentes-Afflick's scholarly work has focused on the broad themes of Latino health, acculturation, immigrant health, health disparities, faculty misconduct, and faculty development. Next, we will turn to Dr. Rashawn Ray. Dr. Ray is a David M. Rubenstein Fellow in Governance Studies at the Brookings Institution and Professor of Sociology and Executive Director of the Lab for Applied Social Science Research at the University of Maryland, College Park. Dr. Ray's research addresses the mechanisms that manufacture and maintain racial and social inequality, with a particular focus on police-civilian relations and men's treatment of women. Third, we will hear from Dr. Paula Lantz, Associate Dean for Academic Affairs and the James B. Hudak Professor of Health Policy in the Gerald R. Ford School of Public Policy at the University of Michigan. Dr. Lantz is currently engaged in research regarding the potential for and the challenges associated with using social impact bonds to fund public-private partnerships aimed at improving health in low-income populations, including Medicaid beneficiaries. Finally, we will hear from Dr. Lawrence Gostin. Dr. Gostin is a university professor at Georgetown University and founding O'Neill Chair in Global Health Law. He also directs the World Health Organization Center on National and Global Health Law and co-chairs the Lancet Commission on Global Health and the Law. Dr. Gostin has held high-level positions in WHO and has served on numerous expert panels. I should also mention that he will need to leave us before the close of today's session because senior White House officials have asked him to advise them on the vaccine rollout. He extends his apologies for his early departure, but no apologies are necessary when public service calls. So, Elena, we will turn to you first.
Thank you very much for the introduction. Thank you for inviting me to participate in today's exciting presentation. I look forward to sharing my reflections and learning from all of my colleagues. I'm going to talk about improving the health of immigrant populations. Let's begin with the global perspective on immigration. According to the United Nations, 3% of the world's population lives in a country different from the country of birth. The United States has the largest number of immigrants of all countries. According to the United Nations, approximately 46 million. The second most common country for immigrants is Germany, with around 12 million. So when we turn to the American context, in general, first of all, according to the Census Bureau, the number is around 43 million. You see right away why I'm going to call for data as one of the hopes for the Biden administration, because it's very difficult to plan or to make statements when we have inaccurate or fluctuating calculations. But in general, according to the Census Bureau, 14% of our population is foreign born, representing approximately 43 million people. Not every country is represented among the immigrant population to the US. This slide depicts the flags of the top 4 countries in terms of their representation among immigrants. Starting at the upper left and going clockwise, we have China, India, Mexico, and the Philippines as the top 4. We're focusing on health today, but I want to just say one thing about the impact of immigrants in the workplace. From 2005 to 2015, new immigrants are said to have accounted for 50% of the growth in the working age population of the US. And in the next 20 years, it is estimated that immigrants will be essential for replacing retirees who are aging out. When we think about the US population, around 319 million people, we can think about how the population compares by citizenship status. In a report from the Kaiser Family Foundation that I will reference several times, among adults on the left-hand side, you can see that 93% of our population is either US-born citizens or naturalized citizens, with 7% of our population representing non-citizens. The figure on the right highlights children, because children are both a subset of the population, but with unique attributes. And so among children, the proportion of non-citizens is much lower, 3%. So overall, 7% of our population are non-citizens, and among children, that's 3%. Childbearing women are another unique subset. These are data from the National Vital Statistics Report documenting ethnic variation in the proportion of US-born childbearing women. Overall, among women who gave birth in the US in 2018, nearly 80% were US-born. However, when we disaggregate by maternal ethnicity, you will note that 93% of white women, US-born, slightly more than 80% of Black women who gave birth were US-born, as compared to 53% of Latinas and slightly less than 20% of Asian women. I have a few comments about undocumented immigrants. Terminology is important. I will return to that theme, but undocumented immigrants are a special subgroup among the immigrant population. And according to data from 2017 reported by the Pew Research Center, in that year, there were 10.5 million undocumented immigrants in the US. Almost half were from Mexico, almost 20% from Central America as a region, and 14% from Asia as a region. Who are undocumented immigrants? We probably all have a certain image in our head, but 40% of the population of undocumented immigrants overstayed their visa. So came here on a student visa, on a work visa, on some sort of visa, and then stayed past the expiration date. 60% have resided in the US for more than a decade. And overall in the workforce, 5% is undocumented. And the representation of undocumented workers is especially prominent in the agriculture, construction, and hospitality sectors. It is estimated that more than 4 million children have been born to undocumented parents. So if we turn now to health, what can we say about the health of immigrants, and what are my hopes, and I hope our shared hopes for the Biden administration? I'm going to focus mostly on insurance, partially because it's most of what the data allow us to comment on, but also because insurance is in many ways a gateway to health services. Relying again on the data reported by the Kaiser Family Foundation, overall, this slide depicts the breakdown by citizenship status among uninsured adults in 2018. 70% of that group were US-born citizens. However, 24% of the uninsured adult population are non-citizens. If we stratify instead by citizenship group, whether one is a citizen, lawfully present, which is a synonym for documented immigrant, or undocumented. In this slide, you can see that undocumented immigrants, about 45% of undocumented immigrants are uninsured, as compared to slightly more than 20% of documented or lawfully present immigrants, and only 9% of citizens. Turning again to special subgroups, uninsured women are a vulnerable and unique subgroup. The Affordable Care Act expanded access to insurance, and you will all know that states made a decision whether or not they wanted to accomplish the requirements of the ACA through expansion of Medicaid. But in 2018, there were 10.8 million adult women uninsured in our country, including 1 million women who reside in states that did not expand Medicaid. So when we talk about immigrant health, it's important in short order to think about this from the lens of women and of children. And for children, what is very striking is that their insurance status depends not only on their own citizenship status, but also on the citizenship status of their parents. This slide depicts the proportion of uninsured children among citizen children. So these children as citizens should be eligible for some form of insurance. But you will note that citizen children with citizen parents, only 4% of them were uninsured. But citizen children who have 1 or 2 non-citizen parents are twice as likely to be uninsured. There are a number of access barriers for those who are non-citizens. The first to consider is income. We know that low-income people in our country experience many barriers to insurance status. Part of this is variable definitions of Medicaid coverage, and it's also a function of income because many immigrants have low income, and so just straight income becomes a barrier. Employment status is another barrier because many of our non-citizens are employed in jobs that do not offer employment-based insurance, which is the primary way through which people are insured in our country. I already told you that undocumented immigrants are especially represented among the agriculture and construction sectors, which often do not offer insurance. There are also eligibility restrictions and complex eligibility rules that have a major negative effect for immigrants. And under the ACA, undocumented immigrants became completely ineligible for Medicaid or the marketplace. So undocumented people fall into a very special restricted category. We can't overestimate in many ways the role of fear. Fear has a way of permeating a community, and sometimes the impact of fear lasts longer than the policy change on which it is based. Public charge is a very particular element, and as noted in the middle of the slide, public charge allows federal officials to consider whether an applicant for immigration or citizenship has used non-cash programs when they make the determination of eligibility for citizenship. So use of Medicaid, if you are not pregnant, could be used under a public charge rule to impact the likelihood of achieving citizenship. And these are the kinds of fears that spread like wildfire among immigrant communities. In November, the public charge rule, which was implemented under the previous administration, was vacated. But as I note, the impact is still lasting, even if the change has been implemented. I want to say just a few things about COVID and undocumented immigrants in particular, and I encourage you to read this piece by Drs. Page and Flores Miller in the New England Journal. They highlighted their experience caring for undocumented immigrants with COVID. They noted communication challenges. We know for all patients who experience serious illness with COVID that the PPE, the face mask, the regular mask create a lot of communication challenges. When you add language, and sometimes there are even indigenous languages, not Spanish or not a standard language, then the challenges are compounded. I alluded to fear of public charge, but there are many other fears about interacting with institutions, including being deported or having other consequences by seeking care. That clearly can have an effect on immigrant health. And although we are all encouraged to work from home, be safe, wear a mask, etc., we know that undocumented immigrants often work in sectors where they are not paid if they do not work, and their work requires them to leave home to complete the terms of their employment. So that right there is a structure that is in opposition to public health practice. And housing instability for undocumented immigrants is very common. So I have 4 hopes for the Biden administration. I'm going to just give you a few ideas about what they are. They focus on terminology, on data, subgroup variation, and policy reform. First, on terminology. We need clear, consistent, and respectful terminology to describe immigrant populations. The words that we use, even in the data that I presented to you today, include words like citizen versus non-citizen. We could think about immigrants in terms of birthplace. For immigrants, sometimes they are called foreigners. Historically, they've been called aliens. Documented immigrants can also be called lawfully present, legally permanent. So there are a number of terms that are used. And in undocumented, we're all familiar with the use of the term illegal immigrant. So I hope that we will develop both consistent, clear, and respectful terminology to advance the health of this population. Turning to data, we need to collect data on birthplace and other aspects of the immigrant experience so that we know how many immigrants do we have, in what categories do they fall, what are the unique health risks and health outcomes that we need to consider. And because immigrant health is a longitudinal experience, we need to also focus on longitudinal data. Often we have a series of cross-sectional snapshots and we're trying to interpret how those data are related. In terms of subgroup variation, I focused only on ethnic variation in the proportion of US-born childbearing women, but everything that I said there about variation is true when we look at ethnic subgroups. So we need also to collect data so that we can properly identify and address the needs of subgroups. I want to highlight for you 2 programs through NIH, through the National Institute on Minority Health and Health Disparities. There are increasingly funding opportunities to address and understand the health risks among immigrant populations. And this particular program includes clinical trials as an option. So there are federal funding opportunities in this area. My final hope is around policy reform. I believe that we need national reform around immigration, and that also ties into health reform for immigrants. At the national and state levels, I believe that we need Medicaid reform because it is a shared federal-state program. You may have heard about President Biden's announcement of the US Citizenship Act, which would create an 8-year pathway to citizenship for those people who were undocumented, who were residing in the US on or before the 1st of January of this year. There also have been executive orders issued revoking the exclusion of non-citizens from the census, which you may know has been an issue, and a lot of activity around DACA and Dreamers, and so we have already an executive order in that area. These are very important policy changes that will impact immigrants and immigrant health. In California, where I am, we like sometimes to take matters into our own hands and we like to say that we blaze a trail. So there are ongoing efforts within the state to make state level reforms that we hope might have a national impact. So in closing, there are many gaps between what we know and what we need to know about immigrant health. There are policy changes that can be enacted, and I'm very hopeful that under the new administration, we will have meaningful improvements in immigrant health. Thank you. Back to you, Dr. Cohen.
Thank you, Elena. Let me just turn this right back on. Thank you, Elena, very much for that. Rashawn, we're going to turn to you next.
Okay. I definitely want to thank everyone for this opportunity, Dr. Cohen, as well as people in the School of Public Health, Milbank Quarterly. Thank you for giving me this opportunity to have this conversation. I want to spend some time talking about COVID and systemic racism. I'm going to completely build off of the last presentation that we just heard to really double down on how structural conditions explain racial health disparities. One of the things we know from 2020 is that it wasn't simply about COVID-19, but it was also about a heightened awareness of police brutality, particularly involving Black people, but also an economic collapse, and how all of these pandemics oftentimes collide on Black and Brown people. There's a key stat that I've been highlighting to really show the disparities when it comes to COVID-19. And you can see it in the middle in bold. In short, we know that Black people are about 3 times more likely, 2.5 to 3 times more likely to die from COVID than whites. But there are also disparities for other groups, for Latinos, indigenous groups, Asian Pacific Islanders. And one thing we know is that if Blacks and whites had the same COVID-19 disparity or the same COVID-19 outcomes, that around 22,000 now, Black people would still be alive in the United States. So we're talking about grave consequences in looking at this. I've been writing extensively about this over the past year, wrote a piece at Brookings, How Are Blacks Dying at Higher Rates from COVID? Well, it doesn't have much to do with people's biology or even their behavior. There are a lot of people that probably some of us on this call would wish that their behaviors were a little bit different in terms of mask wearing and not going in mass gatherings. But it's really about the way the structural conditions undergird pre-existing health conditions. In particular, we see 6 outcomes that really manifest for Blacks. First, they lack healthy food options. They lack recreational facilities and spaces in the neighborhoods they live in. I've done extensive work on physical activity and weight outcomes and know that this has a lot to do with the neighborhoods that people are in. They also live in densely populated areas. Part of what that means is that you are less likely to engage in social distancing. And we really see the ways that social distancing is oftentimes a privilege. They are also more likely to be new essential workers, less likely to have healthcare access. And even when they do get that access, they are less likely to receive equitable healthcare. They are oftentimes spoken to instead of spoken with when we look at the patient-physician relationship. And there was a study early on during COVID showing that Blacks were 6 times more likely to be turned away from COVID-19 testing and treatment. This is particularly true as we see spikes in COVID. Part of what happens is that paramedics and first responders, people who work in emergency departments, are asked to use discretion about who they think might be able to survive the COVID pandemic. Well, we know from other health outcomes, such as the maternal mortality rates, that Black people's bodies are viewed as less savable and less valuable. And it highlights this gap. There was a recent situation, a tragic incident of a 39-year-old Black man who died in the parking lot of the hospital because his 3rd time going to the ER, to say that he needed help, he was turned away and they sent him home and he died in the parking lot. These are the type of outcomes that we're talking about that manifest. When it comes to work, essential work, and we just heard this as well. When it comes to essential work, it's a big deal, particularly for Blacks and Latinos. Black workers are overrepresented in low-wage essential jobs. About 20% of frontline occupations are filled by Black people, despite representing around 12 to 13% of the population. One of the things we know, a study that just came out, showing people or groups of people, depending on their occupation, that had the highest risk of dying during the pandemic. And of course, it highlighted some of these jobs: cooks, line workers in warehouses, agricultural workers, bakers, construction workers. And I think it's something that we should all bear in mind as we're ordering food out, as we're ordering Instacart, that these people's lives are literally being put on the line. These are jobs, this was in the state of California where this study looked at, jobs that have increased the mortality rate by over 50% since pre-COVID compared to COVID. These are the occupations that are hardest hit. We also know that when it comes to Black Americans, particularly Black men, that early on there was this fear of wearing a mask because of incidents dealing with police brutality and other sorts of vigilante justice or injustice, like in the case of Ahmaud Arbery in Georgia. We also know that COVID has caused issues with people's mental health. So even if people's physical health has stayed the same in some regards, their mental health has desperately suffered. And we can look at some of these changes from before COVID to kind of right in the middle of COVID. We see these spikes. And oftentimes for Blacks and Latinos, low-income groups, we see it at even higher rates. So what do we do about all of this? I think it's a few things, and we just heard this. Look, we have to continue to do a better job of collecting comprehensive data. We also have to have testing and vaccine disseminations in predominantly Black neighborhoods, in particular using Black churches, barbershops, community centers, hair salons. Some of that picked up some of the work that I recommended, particularly to Congressman Hakeem Jeffries and Governor Cuomo, was something that they implemented. We started to see decreases in New York by placing testing sites in Black and Latino neighborhoods. But workers need paid sick leave. They need hazard pay. They need a living wage. We're starting to see some of that with the vaccine, where major corporations and companies are starting to give people paid time off to be able to go get the vaccine. For people who are working hourly, they're going to go to work versus choosing to go get the vaccine because they're not going to be able to wait in line and take transportation to get somewhere to stand in line for 2 hours and miss 4 to 6 hours of work. So paid time off to get the vaccine is extremely important. And then we need equitable small business administration and payment protection program funding, particularly on this new wave. We know that 41% of Black small businesses have closed during COVID because they're significantly less likely to get this funding. I have a study in Detroit showing that for people who live in Detroit, if you have a small business, you are much less likely to get a PPP loan, and that loan is much more likely to be smaller if you do get it. These are the type of disparities that really collide to highlight these multiple pandemics. So how do we overcome vaccine distrust? We know that vaccine distrust is a huge issue. Well, look, first we have to acknowledge that medical mistrust is rational, that Tuskegee still has a lasting collective memory, that Henrietta Lacks still has a lasting collective memory, that the Guatemalan syphilis study that a lot of people don't know about still has a lasting memory in certain Latino communities. We have to continue to be transparent about the vaccine. And I think a lot of that has been happening. When things go wrong, just say that they're wrong and say that we're aiming to correct these particular issues. We have to ensure effective social media messaging. More than ever, people are on social media. Over like billions of people utilize social media, and a lot of people, particularly young adults, but even some older millennials and some young Generation Xers don't necessarily rely on cable news or newspapers. They're primarily looking at social media. It has to be leveraged in a big way. And I think in some cases, some of these major tech companies are starting to do that. And then we have to leverage these Black community gatekeepers. We need to have vaccine locations in the places I mentioned earlier: churches, community centers, barbershops, hair salons. These are the places where we can meet people that already have key trustee sites for people to engage. But here goes a new one. This is a new big problem. It's vaccine, what I'm calling, along with Keon Gilbert, vaccine gerrymandering and redlining, which is impeding the race for immunity. Part of what we're seeing across the country, from DC to New York, are people from other parts of the area coming to predominantly Black and Latino areas to get the vaccine. In Prince George's County, they actually had to shut down vaccines. Prince George's County is the most affluent, predominantly Black county in the United States. That still didn't stop early on. 50% of the people who were getting vaccines were from other counties. They did not work in the county. They did not live in the county. These are examples of the way that resources get hoarded. And there are a couple things that we need to bear in mind. The big issue is that different state and local vaccine implementation plans are a perfect storm for inequality. And instead, without directly centering racial equity, we will actually be in a difficult situation to deal with the proper vaccine rollout. So what we offer is that equity, reciprocity, justice, and engaging in anti-racism are models that can be applied to determine who qualifies for vaccines. So obviously race can be used, but other markers of inequality and structural racism can be used, like zip code could be a measure that can look at social vulnerability. I mean, we could also look at census tracts, but zip codes becomes a little bit easier way. And of course, this is in line with CDC's social vulnerability index. It's in line with the area deprivation index. These are measures that look at neighborhoods and look at geographic based vulnerabilities that can end up targeting Blacks, Latinos, people who are low income, also has transference to people who are in rural America who might be predominantly white. And so these are the sort of things that we need to do to address the vaccine issue. And what my hope for the Biden administration is that those racial equity executive orders that were put in place last week, over the past couple of weeks, that we center these particular issues when it comes to dealing with the COVID-19 vaccine.
Thank you, Rashawn. That was great. We will turn to our third speaker now, Paula.
All right. Sorry, can you see that? I'm trying to get it into the mode for, sorry, everyone. God, I teach every day and I screen share, and of course it's not getting into presentation mode. Sorry. There we go. Okay. Hi, everyone. I am so delighted to be here today. I really appreciate the invitation to speak with you all today in this virtual format and to be part of this esteemed panel of wonderful experts. And I'm really going to be springboarding a lot from what Rashawn was just talking about in terms of COVID, but go to a sort of a higher level and think about population health more generally. I actually have more than hopes for the Biden administration. I'm going to be a little more forceful. I have expectations and I have some recommendations. And sort of to summarize what I want to be talking about for the next 10 minutes or so, I really do believe that the Biden administration needs to be explicitly guided by a model of health that emphasizes the social drivers and the social determinants of health at the meso and macro levels, at the midstream and upstream levels, and that we just have to do a better job in this country to avoid the medicalization of health and the conflation of health and healthcare. I'll talk about all these things in more detail as we go on. Second thing is that I believe the focus of policy, not only at the federal level, but at the state and local level as well, for health improvement needs to be focused on efforts and reforms on social and racial equity across a wide variety of policy domains, and that this is action that needs to be committed to. It's goals, action, and responsibility from all agencies in the federal government beyond the Department of Health and Human Services. We have to think that the health of the nation is the responsibility of every department, agency, nook and cranny, and silo of the federal government. So there are a lot of models out there for thinking about health, and anyone on this webinar today with a background in public health knows the social ecological model of health and other models of health. And I want to talk about that a little bit, but it's really more than academic. If we're going to improve population health in the United States and improve health equity, we need a model for thinking about what it turns out to be an incredibly complex phenomenon in society, that of health and health equity. So I think, again, everyone is familiar with this model, which really nests health, which of course is expressed in individual people within individual bodies. But those individuals are nested within interpersonal relationships and institutions and communities. And then of course, public policy and the social structures of society are driving all of those layers of things that end up influencing health. So again, there's other models out there, and many are just sort of, they make the pithy but really important point that we can talk about the downstream manifestations of health within individuals are things that are driven further upstream, midstream, at the meso level, upstream at the macro level. And it's this flowing of factors and drivers that again leads to the expression of health or illness within individuals, but all these things are flowing to impact people downstream. And so I think everyone's like, yeah, we've heard all this before, but what's happening out there in the world, and especially among policymakers, so outside of the academy and pointy-headed research that people like me conduct, is a lot of conflation of health and healthcare. It's rampant. There's also a lot of conflation of thinking about health disparities as being healthcare disparities, health equity, healthcare equity. These are not the same things at all. When we think about healthcare, it's really one of the many, many drivers of health at both a population level, but also at an individual level. But because all these other things drive health, healthcare is not the savior. Healthcare intervening at the individual level is not where we should put all our policy eggs, not the basket in which we should put all of our policy eggs, or the way in which we think about health and the ways to intervene upon it. So health policy is not just healthcare policy, and certainly not health insurance reform, but those things get equated a lot. And then, I've been writing a lot the last few years about what I see as alarming growth in population health management. And I'm alarmed by it because I think, again, it conflates health and healthcare. And also importantly, the conflation of the social determinants of health with the expression of social needs at the individual level is extremely problematic, but again, growing. And I'm sorry to say that I saw a new policy brief that came out today by Milbank. Sorry, Alan. That I think conflates the social determinants of health with individual patient social needs, and that's a problem. And why is that a problem? And why have I been sort of ranting about this actually for 15 years now, and I'm tired. And again, I feel like it's getting a lot worse. So this idea that we're going to intervene the best on health through healthcare, or now more thinking about, social welfare services at the individual level, this conflation is a problem for thinking, and identifying problems, but it's also problematic in terms of resource allocation and thinking about interventions, because it drives everything downstream. It makes more investment at the illness and social needs at the individual level. And then it overvalues healthcare, insurance, access, quality, payment reform, and the healthcare delivery system as the priority paths towards health. It's also a problem, so it misdirects attention and resources. Also, it's not the comparative advantage of the healthcare delivery system to address the meso or midstream or macro or upstream drivers of health. And that is not a criticism of the healthcare delivery system. It is just a fact. That is not its job. That is not what the people within it are trained to do. And also, I worry about when all the investments in healthcare fail to reduce disparities or improve population health. It does, for some people, reinforce notions that some populations are undeserving, these problems are intractable, or that health inequity is just an inevitable phenomenon in society. So what can we do about this? And again, this is going, it's not a problem of semantics, it's a problem of thinking and conceptualizing health in this complex sort of way. So like Rashawn mentioned, I'm really encouraged by all the signals and the efforts coming out of the Biden-Harris administration so far that are really, really emphasizing the importance of social equity and racial equity. Susan Rice, who is leading Biden's racial equity initiative, said earlier this week that in every department, in every aspect of what is going to be done at the federal government, we need to be intentional about infusing equity and racial justice. And that's great. And I think that's the best thing that will be done for population health. But I also think that it shouldn't be stealth. It should be embraced and claimed explicitly that investing in all these other areas in terms of both social and racial equity is exactly what we need to improve population health and move towards health equity. Economic policy is health policy. Poverty prevention policy is health policy. Housing policy is health policy, et cetera. And of course, healthcare policy is health policy. And God knows we have a lot that's broken in our healthcare system and that needs to be fixed. But really, to reach our goals, we're going to have to invest in all these areas of policy to achieve better health in the nation. Excuse me. So getting a little bit out of the abstract clouds and drilling down a little bit more, where do I think some policy action can happen? And I actually think that taking the Healthy People 2030, which was just announced quite recently. So this is a strategic plan and blueprint for the health of the nation. There's some possibilities here for the Biden administration to really move the efforts more in the direction that I'm talking about. So Healthy People 2030, the plan, it already has 355, count them, core objectives. And on top of that, it has developmental and research objectives. But within Healthy People, so that's a lot. There's a lot in there. And there are some objectives in there that do relate to social issues of people. And then there are actually a few that I would say are actually social determinants of health. They're sort of above individual people. Within the Healthy People 2030 framework, there also is a set of what's referred to as leading health indicators. And this is a subset of high priority objectives that are supposed to drive action and resource allocation towards improving the health and well-being of the population. So in this set of 23 leading health indicators, there are some related to the social drivers of health. Exposure to unhealthy air is one, the 4th grade reading level at or above proficiency, and then also household food insecurity and hunger. So 3 of these 23 LHIs do relate to social drivers of health. However, there's opportunity, and I'm recommending to add more. And maybe not officially to the leading health indicators, but for the Biden administration to embrace these. And actually, the ones I'm going to recommend are ones coming out of an effort that I was part of. So I was part of a National Academy of Science, Engineering, and Medicine committee that produced a consensus report at the request of the Department of Health and Human Services for the leading health indicators. And so we actually recommended, and there's a report you can download and read, including more leading health indicators for the 2030 Healthy People 2030 that are social determinants of health, social drivers of health at, again, these higher levels, because that's what we think is driving the health and the shameful health inequities that we have in our country. And so some of the ones that we recommend in this report are housing, reducing the proportion of households that spend more than 30% of their income on housing. So making housing more affordable in this country, reducing poverty, civic engagement, reducing what's referred to as the neighborhood disinvestment index. So improving neighborhood investment, reducing residential segregation, and then lowering the heat vulnerability index. All right, so I'm gonna sum up here again. My recommendations for the Biden administration are to be more explicitly guided by a model of health that emphasizes the upstream social drivers and determinants of health, and avoids this conflation of health and healthcare and social determinants of health, which with expressions of social factors at the individual level. To focus health policy efforts and reforms on social and racial equity, and then commit to goals, action, and responsibility for health of the nation across all the agencies in the government beyond HHS. And we can start that effort by looking at adding new leading health indicators. Thank you.
Thank you very much, Paula. Great slides. And I saw comments from the audience to that effect. So we're going to move to our fourth speaker. Larry, bring us home.
Okay, thanks very much, Alan. And just really great privilege to be with you and Sandro. It's, you know, I've admired both of you for so many years, and it's great to work with you. And this has been a great panel. I can't say that there is one word that these wonderful panelists have said that I disagree with. I think that they're all inspiring. I thought what I would do is, you know, focus more on law, policy, governance. And so I want to talk about my hopes for the Biden administration. I also believe that, you know, many of them will come true if we can get Congress on board, which is a big if, of course. But I'm going to talk about public health, healthcare, even though I totally agree with Paula that healthcare is a smaller contributor to human health, and that social determinants of health are much more important. Equity, and then I also want to widen it out globally, because he is the President of the United States. We don't talk very much about our international health responsibilities, so I want to end with that. So, you know, on the public health side, I think that public health and pandemic preparedness are crucially important to me. This begins, of course, with the public health infrastructure, which has really been decimated in many years. You know, Sandro and I have written about this together. There has been a starvation of funding, not just at the CDC, but also, and most importantly, at the state, local, and tribal health department level. And we've seen this play out in a very poor vaccine rollout because of this weakened infrastructure, among other reasons. We've also seen a decimation of the public health workforce, and with major resignations and retirements over the last number of years. This has certainly been going on even before President Trump, but accelerated under Trump with his undermining of public health agencies and his undermining of science itself. So I would like to see consistent and ample and sustainable funding. I would like to see a well-trained and well-recruited and well-paid workforce. I would like to see vastly improved data systems, and I can pinpoint at least 3 areas of data systems that are illustrative, but only illustrative of the problem. I mean, one, you'll recall that HHS circumvented CDC and took hospital COVID data directly at the HHS level and farmed it out to a contractor, private contractor. Of course, that was unforgivable to short circuit CDC, but also we know that CDC's data systems are not state-of-the-art 21st century data systems, and they need to be, as is true for state and local health departments. Another good example, I think, is our weakness in genomic surveillance. We've seen this in relation to the COVID-19, SARS-CoV-2 variants, with countries like the UK far in advance of the US in being able to rapidly and professionally sequence and track mutations in viruses and other areas. And then thirdly, is to have much more granular data, because unless you know where problems arise, which communities are hurting and why, you can't do anything about it. And so a granular data really with thick detail is absolutely necessary for health equity and health justice, including racial justice, which Rashawn talked about, I thought, quite eloquently. And so for public health infrastructure, sustainable funding, workforce, data systems. The healthcare system is also deficient. We like to call it a healthcare system, but in truth, it's really, America is one of the only, if not the only, high-income country that really doesn't have a healthcare system. And so there are a lot of things that can be done with healthcare, both the Affordable Care Act and with Medicaid as being the two major examples. We had an article on this about Biden executive actions that he could take. He's already begun to take several of the executive actions that we recommended in that JAMA article. But with the ACA, it needs Congress, but it would certainly be good to see a public option for the Affordable Care Act. And I'm not expecting a wholesale change to our health system, but I think having a robust public option would be a major step toward both increasing competition, but also in ensuring more affordable and widespread health coverage. On the ACA, there's a lot of things that the administration can do without Congress. For example, it can significantly limit short-term care plans, which President Trump expanded widely. And these things are bare bones, not full coverage, and it enables younger, healthy populations in particular to short circuit ACA qualified plans, and which undermines the system. I would like to see expansion of enrollment opportunities, which I think is extraordinarily important. Biden has begun to do that in the enrollment and also driving consumers toward the insurance exchanges and not toward private companies. And I would like to see greater subsidies for health providers, both for providing healthcare for poor and minority and disadvantaged communities, but also to use incentives to allow health providers to address the socioeconomic determinants of health, while fully agreeing with Paula that that's not where the action is. It's really much more in income, poverty, education, transportation, and other deeper drivers of health. Medicaid expansion is extraordinarily important. When the Supreme Court upheld the Affordable Care Act the first time, Justice Roberts actually had a very troubling plurality decision, even though we all applauded the fact that he supported the ACA. First was the tax provision, which on the individual mandate, and that's now before the Supreme Court again, although I'm expecting the court to have the ACA survive. At the same time, we've seen that the Supreme Court allowed the Medicaid expansion to be voluntary, which was the other part of Roberts's opinion that was very destructive. And as a result, we have up to a dozen states, mostly in low-income states with a lot of low-income people who have not expanded Medicaid. So I would like to see much more robust federal subsidies for states to expand Medicaid in many ways, both for public health, socioeconomic determinants of health, and the Affordable Care Act. I think everything depends on equity. Equity is crucial. I've often thought that justice is at the heart of public health. I often think of Martin Luther King, who said that all inequalities are unjust, but the greatest inequality are health inequalities. And I think he was right. And we can see that COVID was just a manifestation of it, but we've seen it for decades upon decades, if not centuries, in the United States in terms of higher burdens of disease, everything from AIDS, TB, through to hepatitis, through to cancer, through to cardiovascular disease, and a whole range of health conditions. I want to end by talking about global, because I don't think it's talked about enough. There are some very discrete things I would like to see the Biden administration do. Certainly, we recommended, and it was delighted to see on day one, Biden rejoin the World Health Organization. I thought that President Trump's notice of withdrawal of WHO Secretary General Guterres was one of the most ruinous presidential decisions in my lifetime. So I'm glad that Biden is reversing it, but the distrust of America is great globally, but he has to do more. He has to spearhead with our allies a sustainable budget for the WHO. Currently, WHO's budget is about the size of one large US hospital, which is completely incommensurate with its global mandate. At the same time, it only controls 1/4 of its entire already inadequate budget. No organization can survive when 3/4 of its budget are beyond its control. And most of that control is placed in high-income countries like the European Union, the United States, the Nordic countries, and the Gates Foundation, not in WHO itself. Beyond that, we need to see WHO have much greater powers. There's currently a reform commission formed by WHO as part of the independent panel to reform the international health regulations. It was very, very clear that there were deep problems early on in the pandemic when China was not reporting promptly, accurately, and transparently to WHO. It's a year later after the pandemic struck that WHO is first on the ground in Wuhan to investigate the origins of the zoonotic leap of the SARS-CoV-2 infection. And that's just unconscionable that it would take a year to negotiate. And even now, there's the terms of reference do not allow WHO full access to data and information. I also recommended, I was very pleased to see President Biden promise to join COVAX, which is the global vaccine facility. But he has to do much more than join COVAX. Even if COVAX were fully funded, it would still, and it was completely successful, it would still only vaccinate 20% of the population of low-income countries by the end of the year. And that's very optimistic. Would the United States or Europe accept the 20% vaccine coverage? I really do not think so. It is entirely unequitable, in my view, for the United States and Canada, the European Union, and others to hoard vaccines. We've advanced purchased vaccines enough to vaccinate double our population, while the rest of the world has extreme scarcity of doses. We should be donating some of our doses after we've vaccinated our most vulnerable populations, and allow other countries to do the same thing for them. This is not only a moral imperative, but I think it's very much in our national security interests, because as long as this virus is rampantly circulating globally, which it is, and it's likely to do more, the more opportunities there are for this virus to mutate, for new variants, and those variants, as we've seen, can be more transmissible and also resistant to vaccines. They could also in future become more pathogenic. And so therefore, the variants will become more troublesome for everyone, including the United States. And these variants, including other clusters, will continue to reseed themselves in the United States. So it's very much in our interest and our allies' interests to vaccinate the world. It's the right thing to do, but it's also a smart thing to do. As Dr. Tedros said from WHO, no one's safe until everyone's safe. And so that's my menu for the Biden administration. It's beef up the public health infrastructure. It's expand the ACA and Medicaid and make them more robust. It's having a ruthless focus on equity and justice. And it's extending its idea of equity and justice to the global citizens of this world that have equal worth as those in America. So that's my whirlwind tour. Thank you very much for inviting me, and I can stay for a short moderation period, although I might be having to go to the Biden briefing soon, so I apologize for that.
Thank you very much, Larry, and thank you to all four of our panelists. I heard a number of common themes or threads come through the four presentations. Several of you mentioned the importance of having better data, more granular data, and better data systems. Most importantly, the ability to measure certain things. Paula, for example, offered a number of indicators that we should be looking at. I also heard a common theme with respect to terminology and definitions, which I think are going to be very important. Elena had mentioned, for example, the difficulty right now with terminology regarding undocumented immigrants versus other terms that are used to describe those populations. I also heard a theme of equity and justice come through from all four of you. So I think there's a lot in common here. And what I'd like to do is just put to you a couple of questions before we go to the audience for questions from them. But one of the concerns that I have is that we've just come through a period where the previous administration had various agencies functioning as if they were strictly silos. They were off doing their own independent things. There was no coordination across agencies within government, and certainly there was little or no coordination between the federal government and state governments, and nowhere did we see it more clearly than in the way in which the COVID-19 pandemic was handled. And we're seeing it now play out, unfortunately, in the case of vaccine distribution. My concern is that the Biden administration, if they try to return to what had been the Obama administration era practice of government, they'll still fall short of that. And one of the things that Paula mentioned, which struck me as incredibly important, was committing to goals across all agencies. And it's not just an issue of putting health in all of these different sectors. It's a question of these agencies actually working together and coordinating various policy efforts and reforms. So the question I have for you is, how do we assure that going forward with the Biden administration? How do we get those different agencies to function as a team as opposed to functioning as a group of independent silos? And this also fits with what Elena had been talking about of national immigration policy reform and state level Medicaid reform. How do we coordinate these things? What are your thoughts on that? Who would like to jump in here?
Oh, I'll
Elena?
go ahead, but maybe later, Alan, you can call on us so we don't trip over ourselves. Thank
Go
you
ahead,
to
Elena.
my fellow panelists. I learned so much from you. I think one principle that the Biden-Harris administration could develop is really just an organizing principle, whether these are pillars, whether they're national goals, somehow defining some very big picture goals that that then will relate to the cabinet positions and then further on down with metrics, because we do need clear metrics and accountability, but a coordinated strategy for how to advance them. Sometimes it's an issue of, I guess, packaging how the different activities flow into a general theme. But I think establishing some national goals, clearly assigning responsibility and accountability, following up, I think that would be one way to get your handle around 300 million people in a very complicated environment. Just some simple organizing principles, but accountability and measurement are often, we often fall short on that. So that would be one recommendation.
Okay. Larry, I know you're pressed for time, so if you'd like to address this, I'll give you the opportunity.
Yeah, sure. Thanks, Alan. I mean, it's a really difficult problem to solve. You know, we often talk in public health about an all of government approach, but it's, you know, it's been mostly talk, or sometimes we call it health in all policies. This is something that, you know, these agencies are so big, so sprawling that it's really hard to work together. The only way they can do it is through the White House. The White House actually has to take control. They've done that a little bit with equity. They've got a cross-government equity task force. I think that's a very useful model. And it could choose a few other key areas where there could be better coordination. Clearly, you know, things like, you know, climate, transportation, health, education, all of these things are linked. And so there needs to be some 3 or 4 really big, broad themes with the head of government and the cabinet being making sure that all agencies are moving together. It's the only way that I've ever seen internationally that governments can do it. It's got to be from the top.
Thank you, Larry. Paula, do you want to jump in here?
Yeah, I agree, Larry, 100%. I was going to say many of the things you just said. You know, I think it's been a little over a decade now. There has been this health in all policies movement at the local, city and county level, some state levels, and there was sort of a nascent attempt during the Obama administration at the federal level too. In some places that's backfired a little bit. Some people have even said, like, who died and made health the, you know, driving force behind all of our policies? Why isn't education in all policies the important thing? Why isn't income security in all policies the important thing? So it doesn't, I would recommend against a health in all policies approach, but I totally agree with Larry that what's already emerged from the Biden administration is this organizing theme around racial and social equity. That's what's going to drive health improvement and health equity. So totally behind that. And I think, again, it can even be sort of stealth as to the, you know, this is a health initiative, but I think it's better to sort of say, like, this will go, having this focus on racial and social equity will do a lot for education improvements and reducing educational inequities, for preventing poverty, and for health. So it's a winner.
Thank you. Rashawn, I'm going to turn to you in a second, and I'd like your view on, are we talking about something that is more long-term, or are there solutions, steps that we can take in the short term? In your presentation, you pointed out a number of problems that seem to me to be of absolute immediacy in terms of dealing with them, and we're not doing a very good job. So what can we actually do short-term to meet some of the needs of communities of color in particular?
Yeah, I mean, I think, well, first off, I mean, I really enjoyed all the presentations as well. It was great to hear everyone's perspectives. I mean, I think the biggest thing, and I think someone just put this in the Q&A or the chat, and I try to highlight this, we have to meet people where they are. You know, oftentimes we talk about like we're kind of at the grass tops level, and we really have to get at the grassroots level. Part of what that means in local communities is going to the places where they are. Churches, community centers, barbershops, hair salons. And when I say that, I mean the same way that we leverage testing sites, we have to leverage this for vaccination sites, because there are real barriers right now to transportation. I mean, there were before, but there really are now during COVID. Certain things are still limited in terms of people's ability to move around. The bus line doesn't operate the same way. Trains don't operate the same way. So we have to meet people where they are in those particular communities. I think the other thing that needs to happen is we really have to do a better job of leveraging local trustees. So what I mean by that is we know that there's a vaccine distrust gap. We know that there's just a distrust gap when it comes to healthcare in general. A way to address that is not to necessarily have tons of politicians getting shots, but there are a lot of people in local communities that people trust. And when they see that they have participated in the vaccine, that then they'll be more likely to take it as well. I think the other big thing is, of course, when it comes to essential workers, it is essential. I mean, it is almost an imperative that companies give employees paid leave to be able to take the vaccine. We're starting to see that ramp up. I mean, from Trader Joe's to McDonald's to Instacart. We need to have that happen, not only because those people are hardest hit, but also because when you're an hourly worker, you're not going to spend the entire day trying to do that. And I really don't think people realize how difficult it is for people who are living in places who don't have a car, who work a low-wage hourly job, to try to get to a vaccination site at a place that might have already turned them away. So I think when it comes to some short-term things, that's what we could do. This next stimulus package that Biden hands down, I think because look, that's going to happen. I mean, it's very clear over the past couple of days, just based on his, how he's approaching it. If Republicans don't get on board, it's going to be steamrolled through based on how they're dealing with the filibuster. Part of the other thing that needs to happen there is with the broader equity initiative that's being handed down from the White House. They need to leverage the Office of Science Technology Policy. Part of leveraging that is we know people like us, social scientists, public health scholars, epidemiologists are there, have amazing recommendations similar to what we're providing to help deal with some of these issues. Alondra Nelson, who was running the Social Science Research Center, is now the deputy director of OSTP, has tons of great recommendations on how we address some of these gaps. So I think that can be leveraged to then hand down to states and the local level to say, these are the priorities in terms of what we need to do. Whereas right now, the segmentation for states and cities are just, the segmentation is so huge that it creates tons of inequality in the system. We need to do a better job of standardizing it.
Thank you, Rashawn. I want to pursue this issue of distrust of science a little bit further, and it was something that was raised by a couple of you as well. And it's also a question that is coming from the audience. Are there any specific recommendations that any of you would have for the Biden administration to begin undoing the mistrust of science that had been exaggerated by the previous administration? Are there concrete actions that could be taken to counter those effects, because they've been in place for quite some time? As you had mentioned earlier, vaccine hesitancy, Rashawn, but that's only part of it. And it also filters down from the federal government to lower levels of government as well. So any specific recommendations that the Biden administration could put into place to begin to rebuild public trust in science?
I mean, I'll just say, I think one big thing is it's not always what's being said, but it's where it's being said at. What I mean by that is, and I mentioned this earlier, I mean, when I examine social media trends, I mean, that is where people are getting their information from. And if they're, and we know that there are, you know, if you go on any major social media site now, someone says something about COVID, there's a little link, it pops up. That's great. A lot of people aren't clicking on those things. There needs to be an all-out campaign around equity, centering justice, and centering truth. And part of this means is highlighting some of these issues that pop up in regard to misinformation. Because one of the big things we know about social media, there are these echo chambers that exist. And I've been studying this for the past 6 or 7 years or so, that there are people who are in one part of, say, the Twitter sphere or the Instagram sphere who completely don't see the information of the other. And so part of that means, again, coming out of the White House, there needs to be campaigns that are targeting different constituents of people. And in this regard, I really think the over 70 million people who voted for Donald Trump, I mean, we have to be very clear that even though Biden got the most votes in American history, Donald Trump is second. And the level of misinformation that is going through there is still huge. And so it's not simply about what is being said, but it's where it's being said at. And I don't think that a good job has been done there. I mean, getting on cable news is one thing. That's great, right? A lot of us do that. But there are also a lot of people who don't watch that or who see a clip that is taken out of context. And until those sort of things are addressed, we won't see an increase in trust in science, medicine, and of course, journalism, which is also taking a huge hit.
Thank you. That's a very good point. Elena, let me turn to you. There are a couple of questions from the audience that I think address your particular presentation. People would like you to expand a little bit further on your hope for terminology. Do you have specific ideas for what would be a better term, perhaps, than undocumented immigrant? That's part of it. And the other has to do with the relationship between the immigration policy of the United States and health policy. How can we assure that undocumented immigrants are going to get access to insurance coverage? What in the short term could the Biden administration do to make that possible?
Thank you for the questions. Thank you, everyone, for your engagement. In terms of terminology, I guess I would say, for me, the best is the most factual. So I personally don't mind undocumented immigrant because I think it is factual. One has either the documents that are required by the government or one does not. So there isn't a way to make it nice or the same as a documented immigrant, but to me, the more factual, the better. I find myself tripping over it. There seems to be an emerging trend of saying non-citizen and citizen. I find myself non-citizen, the more words we add, the little clunkier it is. So I personally prefer immigrant and undocumented. So just as factual as we can make it. That would be my suggestion. But I think this is an opportunity for policymakers, for clinicians, people like Paula in public policy. Let's come together. Let's come up with some recommendations about language. And then if we can have a willing partner in the White House, NIH, all the other organizations, let's implement that, reset the bar, because often whatever the government advertises for in terms of funding opportunities, that becomes the terminology that we start to use.
Thank you.
Around immigrant policy and health policy, I think for many immigrants, I appreciated Paula's perspective on health is not everything. I'm a physician, so that tends to be the way I think. But you're right. I mean, education is everything. So everything is all interlinked. It's very hard to carve things out. But for immigrants, I think we need to recognize, and the COVID has really highlighted this, when you have people who are outside of our system, who cannot avail themselves either of the public health recommendations, or who, no matter what vaccination program we are able to implement aren't eligible unless you kind of wink, wink and look the other way. But public health requires all of us to be healthy. And so I think some of it embracing that notion that this is all of us, and maybe there are differences within the all of us group, but every group has to be addressed. Their needs have to be met. Otherwise we will have pockets, and then we know now with the COVID that will not help us. So I think having a health lens on immigration policy is what I would hope. And I think that health often drives immigration policy. So I don't think they're too disconnected, but of course there are many other aspects to consider.
Thank you, Elena. Paula, your comments about avoiding conflation between health and healthcare has resonated with a number of different members of the audience. And there has been a request for you to expand a little bit on your sense of what upstream policies that would be focused on social drivers would likely encompass, going perhaps a little bit beyond what you had presented in your slide. So if you'd like to elaborate, we'd appreciate it.
Sure. Thanks for that giant question. Those of you who've been, thanks for all the engagement. I've been looking at all the questions in the Q&A box, and there's amazing good ones in there. Mm-hmm. Actually, I see a couple of my students in there too, so shout out to them. There's so many important things to talk about, right? But I just think fundamentally, economic security is important. Now, that's not saying all these other things aren't important too, but you know, the fact that we live in a country where 1 out of 5 children grow up in poverty, 1 out of 3 rounding children of color grow up in poverty, that's unconscionable, and that is fundamentally, if you think about, fundamental cause theory, for those of you who have studied that, economic security and the quality of education, especially among children, is so important. And we do not do a good job on either of those in this very wealthy country. So I would focus on that. And then I'm sure a lot of people have seen the big buzz that came out. So the Biden administration is working on a plan for child benefits, it's being called, but this is not healthcare, right? This is like economic support and a range of benefits. And Mitt Romney came out with his own plan yesterday, which actually goes even further than Biden's plan. And so I'm going to be watching that. I think a lot of other people will too. But if the quick and dirty analysis on Romney's plan is that if it was implemented, it would significantly cut child poverty in this country, and also the deep poverty of families in this country. And it's absolutely fundamentally things like that we need.
Thank you, Paula. There seems to be another thread of interest on the part of several people regarding the coverage gap for those living under the poverty level in Medicaid non-expansion states. So the questions are of 2 types. One is, are there any viable options at the moment? And then secondly, there are questions about the potential value and viability of a public option leading to greater equity within the system. So I'm not sure to whom we should address this, but if anyone would like to tackle it, what can we do to get some of these states to come around and expand their Medicaid programs? As I'm sure many of you are aware, there are ballot initiatives in several states, including a major state, a populous state like Florida right now. It's coming up for the 2nd time. It was killed last year. But we'll see what happens in these states right now. But there is more interest in expansion than there was just even 6 months ago. So we're not there yet, and there are still a number of states that are not expanding Medicaid.
Well, I'll just say that, one thought is, should our model of Medicaid be reconsidered? Is this federal-state partnership the most effective strategy? Because we've seen how much variation there is, and, how can we allow that to continue? But the structure of Medicaid allows it. So one, blow it up and start all over again option would be let's have Medicaid as a federal program rather than a federal state partnership. Because otherwise, I think too many things depend on who's in power, what are the voters thinking that time. It doesn't come from a principled place of, we want everyone to have some form of coverage. And if you're low income, this is your option. So that's a thought.
Okay, thank you, Elena. And we're actually out of time. So we're going to close this now. So with that final comment, we've reached the end of the program. In closing, I would like to thank our distinguished panel members for sharing their insightful comments and their perspectives. I know that I personally have learned much from today's discourse. And if you'll indulge me for just 1 minute, I would like to close on an optimistic note. As we've discussed, the nation faces deep divisions on issues of racial justice and health equity, and President Biden sees his task as working to save the soul of the nation by building back better. Perhaps we may take inspiration from Henry Wadsworth Longfellow's poem, The Building of the Ship. Written at a time when the issue of slavery deeply divided Americans, Longfellow used the ship as a metaphor for the Union. Despite the grim challenges of the time, the poem brims with hope for the future of America. So here's a brief excerpt from the closing lines. Sail on, O ship of state. Sail on, O Union, strong and great. Humanity with all its fears, with all the hopes of future years, is hanging breathless on thy fate. Our hearts, our hopes are all with thee. Our hearts, our hopes, our prayers, our tears, our faith triumphant, or our fears are all with thee, are all with thee. So let us hope that the Biden administration is able to realize many of our hopes and dreams for the future of America. It is imperative that we all rise to meet the challenges that threaten our democracy, our healthcare system, and most importantly, our nation's health. Thank you all. And I now turn back to Dean Galea for his concluding remarks.
Well, first of all, Professor Cohen, thank you. Thank you so much to all our panelists. What a terrific panel. I learned so much from listening to all of you, and I learned perhaps even more from the Q&A with the audience. I want to say thank you to the audience. You know, I entered 2021, I suspect, like many of us, with a mix of trepidation and hope balancing out. And I was hoping, to use the word again, that this panel would tip me more into the latter, into the direction of hope. And I think it did. I actually think you all spoke very clearly about the potential of the moment. And that's what we were hoping to have emerge from this session, is recognizing there are challenges, many, many challenges, but there is potential in this moment. Thank you all for making it clear what that potential is. Thank you for joining us today, to our panelists, to our moderator, and to our audience. Everybody, stay well. Have a good evening.
Thank you.
Thank you.
Bye-bye.